Hey there. How you doing? Good evening. It is so nice to see all of you, to be in our happy place, the place where we know we need to be every Tuesday evening at 5 o'clock p.m. Central Time, which means 6 o'clock on the East Coast, 3 on the West, and 4 in the mountains. And you are with Fertility with Fink. I am Dr. Randy Fink from New Life Fertility in Pensacola, Florida. And as always, it is my pleasure to be with you here as we are every Tuesday evening, where we talk about all the things that are important to you. We've got a few different feeds here. We've got Facebook and LinkedIn. Right here, we've got a YouTube. We've got a couple of Instagram feeds. Here's mine at Randy Fink MD, and here's New Life Fertility. If you have questions for me, as always, please feel free to write them in. If we're not able to get to these questions this evening, you always have the opportunity to email them to me, and we will certainly grab them off the email and head them up first thing in the show next week. And that's Ask Fertility with Fink at firstfertility.com. Again, Ask Fertility with Fink at firstfertility.com. I see my friend Sydney, a wonderful embryologist in Colorado, has joined me here. Hi, Sydney. Thank you so much for being here. Notice the glasses. I will tell you, folks, so it's 86 degrees in Pensacola today. It's a warm one out there, and it's pretty warm inside here as well. So I'm kind of sweating a little bit. So forgive me for being a little glossy here, but can't be helped. It's all with a good heart. All with a good heart. Let's see who we have here. My friend Angela with the name I otherwise can't pronounce. Hello, Angela. Nice to be here. Sharmila, as always. And it is fabulous to see you here. And even more fabulous, Sharmila, to see that you are pregnant after everything that you went through to get there. It's just fabulous. Hey to Nick Betez. Thank you again for being here. Jazzy Poo. Hello. Hi, Run a Girl Training. Good to see you as well. Jenny, nice to see you also. Sharmila, one special shout out here, and that goes to the Bama Gal. The Bama Gal is my lovely and wonderful mama, who is sitting watching me in Mobile, Alabama, not too far from where I am, with my dad close by her side. And she says, I love that fertilizer with Fink. And I said, it's not fertilizer, Mom, it's fertility. Fertility with Fink. She says, oh, I wondered why. So we got that all squared away now. All right, so let's see. What did we have there? Sharmila asked, I've observed mood swings and depression after stopping low-dose naltrexone. Is that common? So low-dose naltrexone, as you may know, is a medication that is used to boost the immune system. Really what it does is that it stimulates our production of endorphin in our bodies. And we Run a Girl Training can tell us about endorphin there. Endorphin is the thing in our body that makes us feel good, the runner's high. If you've ever seen or if you've ever experienced having a baby, it's kind of interesting when we talk about that, because having practiced obstetrics for so many years, you can see someone who is extraordinarily uncomfortable, let's say without any pain medication during childbirth. And so she's going through that experience, and it's like nothing that, personally I can even imagine. And then in the next moment, she's holding her baby, and there's this calm that comes over her, and she's looking at the baby, and the calm is just, it's mesmerizing to see it. Well, that's endorphin. Endorphin is what does that to us. And that's what low-dose naltrexone does. Not so much make you feel like you just had a baby, but secreting the endorphin boosts the immune system. So in let's say the anti-aging community, low-dose naltrexone is something that people will stay on for years. Sharmila asks, well, what about the mood swings and depression after stopping it? So Sharmila is pregnant and asked last week, about should I continue this during pregnancy? And the answer was, well, there's really probably no reason to. It's certainly not studied in pregnancy, so we don't, truly know what the effect would be there. Although some people would say it's not a harmful medication, so you can always stay on it. Although, let's say if you end up having to have a C-section, it blocks opiates. So if you need a narcotic type analgesia as it's associated with anesthesia, potentially even in an epidural, then I would say, then that's when it kind of starts to become a problem. But it often is reported that it helps with people's moods. So the fact that some mood swings and depression may be kind of getting uncovered, Sharmila, after stopping the low-dose naltrexone does not surprise me. It shouldn't be anything that's terribly dramatic, although I will tell you, of course, that being pregnant alone is enough to potentially cause depression sometimes and to create some of those mood swings. So given that, I would say I think it's really a pretty normal thing to have that unmasked after stopping it, and I would suspect that it will probably be relatively short-lived. Fingers crossed. Since we're talking about depression and mood swings, tomorrow I'm going to put up a post on my Instagram, Randy Fink MD, talking about, this is Mental Health Awareness Month. Mental Health Awareness Month. A few weeks ago, it was National Infertility Awareness Week, but Mental Health Awareness Month is where we can really focus on those things that keep us going, and how life can affect us sometimes in ways that we might not otherwise choose. And this is a darkness, a loneliness, a feeling of, if you've ever experienced that darkness or that weight, that shadow lurking past you, that of depression and mood change, or the racing thoughts of anxiety and the real discomfort that causes. This is the time where we really focus on those things, especially if you're dealing with fertility problems, that when we add fertility to the already difficult ride of life, as I say, that can really turn this roller coaster ride into a real harrowing type experience. Tomorrow, I'm going to ask, what have you done to help get yourself through and come out on top of that experience? And I really encourage you to take a look at my Instagram tomorrow, if you would. Reply to that so that we can have some things to talk about next week, because I do want to focus again on mental health awareness. We have to spend the time to take care of ourselves every single day, but especially when we're dealing with this fertility business. All right. So hopefully you'll take a look at that. Nick asks, what are your thoughts on PRP and HCG wash and HCG boosters? Okay. Good question. So, these are add-ons that some clinics will offer before embryo transfer. So let's start with an HCG booster. An HCG booster is when you give yourself a little shot of the HCG medication, which is metabolized in your body like LH, luteinizing hormones, and ultimately becomes more progesterone. So when you have a little more progesterone, remember it's progesterone that maintains the pregnancy. If you have done a natural or a modified natural transfer cycle, an HCG booster can give you a little extra progesterone in your body, which can be helpful to the pregnancy. If you did a medicated cycle, then using that extra progesterone really probably doesn't help, because we're already giving you such high doses of the progesterone in the progesterone and oil injection that you're getting. So HCG boosters, very good thing for natural cycles, but maybe not so needed in medicated cycles. Let's see what else we got here. And then as it pertains to PRP and HCG washes, the HCG wash is using some of that pregnancy hormone inside the uterine lining, which is designed to really upregulate, to turn up the volume knob on some of those pregnancy receptors in the lining. And I think there is certainly no harm to doing that. There have been mixed reviews on how helpful it really is. When I was at my former clinic, we used it very regularly, and I felt very strongly about it. I liked it. I still like it. So I think there's no harm to that. The PRP wash, usually I reserve for folks who have had things like recurrent pregnancy loss or have a difficult time in growing their endometrium, making that lining thick enough in order to be able to maintain the pregnancy. So HCG wash, good plan across the board, no harm for anybody. HCG boosters, if you've done a natural or a modified natural cycle. PRP wash, more for endometrium that's not getting thick enough, or for recurrent pregnancy loss or recurrent implantation failure. Tiffany is here. Hi, Shada. Nice to see you as well. The Styles family. Donna Spicy, D Spicy. Let's see. We've got, is it possible high estrogen over 4,000 can cause hives and a huge body rash? I'd say so. I'm on estrogen tabs for a frozen embryo transfer. My estrogen is 4,000 and the nurse says it's fine. I really think that's way too high an estrogen for an embryo transfer there, Angela. And I would ask for a clinician's opinion on that, because with an estradiol level of 4,000, you're really in the range of what you would have if you had ovarian hyperstimulation syndrome at the time of a retrieval and we're trying to do a fresh transfer. And I think that would be a bad plan. So as always, if you are unsatisfied with the answer that you're getting from a nurse, that needs to go to a clinician's attention. And I do not think it's a good idea to do an embryo transfer with an estradiol of 4,000. So does that mean that you need to cancel your cycle? Well, you can argue about that one way or the other, but certainly I would say you need to be cutting down on your estrogen because I do think that's too high. Shada asks if RPL tests, that's recurrent pregnancy loss tests, come back normal, so meaning negative for blood clot disorders, do we still need to do Lovenox with the next transfer? And I would say the answer to that is no. Lovenox is not something that is routine in most embryo transfers. Now, certain places, such as where you're going, Shada, use Lovenox routinely in folks trying to treat the possibility that some people may have something in their body that's causing the blood to clot. And that's what's called a thrombophilia. Thrombo means clot, philia means like. So your body likes to clot. If you have one of those things, then Lovenox is the treatment of choice to prevent those small blood vessels that supply a placenta from developing a little blood clot and stopping the flow of blood. But in the absence of those, no, I do not think Lovenox would be a necessity in that situation. Hi to Julia and Ryman Nick, it looks like. Sarah, good to see you. Let's see, we've got Julia over there as well. We've got some friends on the Facebook, LinkedIn, YouTube side. Appreciate you being here. Sporadiati is here. Oh gosh, I like that name. I could say that one all day. Claire Della Cuesta, I think that says. Our girl, hello to Ariel. Ariel asks, it's Ariel Eden, says, do you recommend acupuncture weeks before a frozen transfer? And the answer is, different people will tell you different things. So the American Society for Reproductive Medicine says that the intervention of using acupuncture does not help IVF-related outcomes. There are many people, however, who swear that acupuncture does help those outcomes. In fact, my former partner did a study on that, and along with his wife, and found that, their outcomes, he believed, were improved. So we, at that time, until recently, I believe, were offering acupuncture at the time of an embryo transfer, when I believe it probably really can make some good in terms of blood flow to the uterus, and in terms of relaxation, in terms of stopping some cramping and things that might be happening in that uterine muscle activity. In the weeks before frozen transfer, I would have to say, in my opinion, call it educated or uneducated, I have not seen that is as helpful. Now, there are acupuncture providers who would say that is the most important time. It's not just immediately before you get the embryo, but rather what you're trying to do is you're trying to create a balance in the body, and that balance should exist well before hours before an embryo is going to go inside. So I think there are a lot of people who would say that, yeah, it really is important. In my personal opinion, I haven't personally seen it, but I would be open to it. If someone told me that's what they wanted to do, I would say, I support you 100%. If they said, should I spend my last dollar on it? And I would say, well, it's a harder sell for me in that regard. A special hello to Angela in the beautiful state of Minnesota, where I imagine it's cold today. I think it's cold up in Minnesota, but I'm very happy you were able to be here, Angela. Thanks for joining me this afternoon. Let's see. We've got. Oh, okay. Angela says, thanks. I do too. Well, good. I hope you feel validated there. And you cut down on your own estrogen and the rash went away. Yeah. Again, I think that's just a little too much estrogen for you there. Hi to R Freeze. Nice to see you this afternoon. Glad you're here. Let's see. One question that I got by email, and by the way, if you can't get your question in here for the live, it's Ask Fertility with Fink at firstfertility.com. And the question was, tell me more about sperm morphology. Okay, we can do that. Sperm morphology. So sperm have a head, they have a neck, and they have a tail. And somebody is talented enough to be able to sit and look at a microscope and tell us whether that head looks normal and that neck looks normal and that tail looks normal. And that observation is what is known as sperm morphology. Now, here's the interesting thing, that in human males, it's normal. What's normal is that 96% of our sperm are abnormal. 96% of sperm are abnormal, and that's what's normal, which means it's normal to only have 4% of sperm be normal. So when there are less than 4% that are normal, that's what's known as teratospermia. Teratospermia, or abnormally low sperm morphology, has not been shown to be a cause of infertility, but rather it is associated with couples who have a difficult time getting pregnant. And certainly in the case of a sperm specimen where there appears to be no normal sperm, like 0% normal forms, it can really suggest that in the IVF lab, there may be some issue with the sperm being able to penetrate the egg, or to fertilize the egg, I should say. Because in the IVF laboratory, we're actually taking that sperm and placing it inside the eggs, and that's called ICSI. So we can get over that, but maybe there's a problem with the sperm itself, because if none of those sperm look normal, you have to ask yourself, is there a reason why? When I see that now, I start thinking about something that's called DNA fragmentation. DNA, what is a sperm? I always say a sperm is a little packet of DNA, of genetic material, with a motor on it to get it from one place to the other. We can look at the sperm and we can see the head and the neck and the tail. We can see how many of those sperm are moving. We can see what direction they're moving in. And we can count them up. But what we can't see is what's happening with that DNA, because that, that's electron microscopy size. It's very, very small, invisible to the naked eye, or invisible, even under a regular microscope. So what can we do? How can we test that? We can do what's called an SDFA, a sperm DNA fragmentation assay. And what happens with that is that the laboratory looks at that sperm and gives us an index that tells us what percentage of the DNA that's in the sperm are considered normal, or which are fragmented. So given that, we can determine if there is an issue there with the sperm. So what can you do if there's an issue with the DNA that's in your sperm? Well, there may be a couple of things that you can do. So first of all, there's some supplements that we would say that you should take. We generally recommend now that for folks who are doing IVF, that, when you do a semen analysis, we always say, okay, wait for 3 days. You want 3 days since you ejaculated, because that will increase the sperm count. That's going to maximize the number of sperm. But you may have heard me say before that quantity is not the same thing as quality. So if ejaculation is more frequent, that is to say, like maybe 24 hours before the collection that goes to be used for IVF, then we may be getting less sperm, but we're getting better quality sperm. That is to say, sperm that have less of that DNA fragmentation. So that's what we routinely recommend to people now, is that you don't have that 3-day window before ejaculation, that you ejaculate at least the day before, and then the collection for your IVF. So that may minimize DNA fragmentation. The process of ICSI in the laboratory, which is where we take that sperm and place it directly in the egg, that will also help with the problem. There is something else you could do, and that's a procedure where we actually extract the sperm directly from the testicle, because that fragmentation of the DNA and that sort of messing up maybe of the way those sperm look, that sperm morphology, right, is the term that we're using, we believe may be happening somewhere between the place where the sperm is made, which is in the testicle, and then stored, which is in the epididymis, which is a little structure right behind the testicle, somewhere between that and where it exits. So it's the travel through the system that seems to be what's messing with the DNA of these sperm in many cases. And so by doing a little block, numbing the testicle and taking the sperm directly from the testicle, and believe it or not, that sounds like a horribly barbaric and horrific procedure. It's very straightforward. And it's actually really pretty painless for most people because everything is very numb. Then we would find that we actually get better sperm from that. So these are options for people with DNA fragmentation problems. But we start to think about that with poor fertilization and with persistent teratospermia or abnormal morphology. And hopefully that gives you way more information than you ever thought possible. Cowsar says 1 week of estrase and progesterone is good enough to start my cycle. So, yep, you're getting a little estrogen, you'll get a little progesterone. So the administration of those things and then the stopping of those things is what induces your body to have a period. So how does that happen? Well, under normal circumstances, your ovary releases an egg. That egg hangs out and waits to get fertilized. If sperm comes along and fertilizes the egg, then kaboom, you are pregnant, and all the things that you wished for have happened. And if not, the brain says, okay, fine. Shut off the hormones, clean everything out, and let's start again fresh next month, which is the signal to have a nice normal period. How does that signal get sent? Well, it happens because when your ovary releases the egg, it leaves behind, well, as that egg is growing in the ovary, it's actually making your estrogen. So that's where the estrogen comes from. It comes from that follicle in the ovary that's going to result in an egg being released. Even if it's not an ovulatory follicle, that estrogen comes from some cells. They're called granulosa cells that surround each little egg in your ovary. Well, so the follicle as it grows is an estrogen making factory. When the egg is released from that little factory, the factory converts, it changes over, and it becomes a progesterone making factory. And it's that progesterone that maintains your pregnancy. That progesterone comes from what's known as a corpus luteum cyst. And it's a cyst that every woman who ovulates has inside their ovaries every single month. It's supposed to be there. So that progesterone is supplying the pregnancy. But if there's no pregnancy, the brain realizes, oh, okay, there's no pregnancy. And that corpus luteum starts to resolve. It starts to go away. And as it starts to go away, the progesterone level drops. And it's that dropping of the progesterone level that triggers you to have your period. So if you get a week or so of some progesterone and then you stop that progesterone, you will get what's called a withdrawal bleed. And that's the same thing as your body knowing that it didn't get pregnant, the corpus luteum shutting down and causing you to have a period. So that's a very good and pretty natural way to do it. Good deal. Hi to Maria King and Midgie 56. Nice to see you this evening. How long into pregnancy will I take Neupogen? Usually that's going to be stopped in the first trimester. Neupogen is also not a standard thing for most IVF pregnancies. It's used in special circumstances, but not too long, pretty quickly, I would say. First trimester for sure. Kauser says, this morning I had my period and I called my doctor and she kept me for 1 week of Estrace and Provera and then start my IVF cycle, like injections and the egg retrieval will be on June the 14th. So I guess the question is, what happens? So why did you get put on some Estrace and Provera? So there can be a couple of reasons for that. Sometimes it helps with the schedule for your IVF, that sometimes it just makes it a little bit more convenient to get your ovaries all on the same page with the rest of the schedule. But the other thing that getting some estrogen and progesterone does, and I too like to use Estrace and Provera or Prometrium in that situation, as opposed to using birth control. There are a lot of folks who will use birth control. Why would you use birth control instead? Well, birth control, it's a combination of estrogen and progesterone. So it's just easy and it's all together in one pill. But there are a lot of people who say, I'm trying to get pregnant here. I don't want to be on birth control, or I never did well on birth control. I certainly don't want to be on it now. And that's understandable. So estrogen or Estrace, estradiol and some progesterone is a good way to do that. It juices up the ovaries a little bit. That's called a little priming. It helps to increase the blood flow that goes to the ovaries, and it may help to kind of wrangle in all those little eggs, because once you start to get the medication that's going to stimulate the growth of your eggs, we really want to get those eggs growing together at the same time, or in synchronous growth, as opposed to growing dysynchronously, which may be one that you have growing at 3 times the pace of the next one. And, they're kind of all over the place size wise. It would be great if they were all roughly the same size, kind of growing together. And so that's one of those things that kind of priming does for the short term. So best of luck with that. Let's see. T. Andres, hello. What supplements help with vaginal? Well, I'm not sure what we mean by that. Supplements helping with that. If you mean sort of generally vaginal health, kind of probiotics is something that is often talked about. And I think in general, probiotics are probably a pretty good idea. But as far as the data behind them for vaginal health, you know what? It's not very strong. They really haven't studied it so thoroughly that we could say that everyone needs to be on probiotics, or even who should be on probiotics for vaginal health. Now, in general gynecology, when we find that there is a recurrent vaginal type infection, something like bacterial vaginosis or a yeast infection, there are some people who just recurrently get these infections over and over and over. And it can be a very frustrating problem because many docs will just kind of keep treating it or test it and treat it with the same thing over and over. There's not great guidance on what you're supposed to do in that scenario to try to break the cycle. So it's a little bit more complex gynecology. But one of the things that we usually look toward is to think, well, there probably is some kind of issue with the bacterial flora in the vagina, because something is allowing that abnormal bacteria to overgrow, things to be out of balance. And so given that, probiotics are a relatively inexpensive way to try to restore normal vaginal flora. Now, some people advocate using using that directly in the vagina. Some people would say, oh no, just a regular taking a vaginal probiotic orally. To tell you the truth, the base of the whole system is in the GI tract. So probiotics that treat the gut should, in theory, have a ripple effect that go through to all the other mucous membranes in the body, including things like the rectum, the mouth, your ears, your nose, and of course your vagina. So I think in general it's a good thing, but hard to say that it is a must for everybody. One of the other things that we would commonly see in folks with recurrent vaginitis would be a low vitamin D level. Now, it really begs the question. If you've had your vitamin D checked, then odds are it was low. So almost everybody, I'd say that 1 in 10 people that I see have a normal vitamin D level. And even when I was in Miami and would take care of lifeguards from Miami Beach, and now here in Pensacola in the sunshine on the Gulf Coast, people are outside an awful lot more, and their vitamin D levels are still low. All right, so maybe we have an issue with the way we track our vitamin D, or maybe our levels, what we're calling normal. Maybe that's off. Vitamin D has kind of become a very popular thing to talk about and a popular thing to replace. And I do feel like a good vitamin D level for longevity, at least as far as anti-aging goes and as far as fertility goes, is between a 60 and an 80. So if you come to see me and we check your vitamin D level and we find that it's 32, I would say, okay, that's great. It's completely normal, but I'd really like to see it doubled. How do you double your vitamin D? A lot of times primary care offices and even certain, specialists will give people prescriptions for 50,000 units of vitamin D to take once weekly. Well, the problem there is that the body just isn't so efficient at absorbing that vitamin D. So there's a liquid vitamin D3 with K2. D3 with K2, I think, is the best way to rapidly get your vitamin D replaced. And I like the liquid version. I'm happy to send you what that is if you want to message me through Instagram. It's Randy Fink MD, and I will send you a link for the one I like. But so we were talking about chronic vaginitis and low vitamin D levels. Maybe it was just a common thing that everybody we were testing had low vitamin D levels because so many people have low vitamin D levels. However, then when we treated those people with vitamin D and fixed that, it seems like the large majority of them stopped having their chronic vaginal infections. And so that's probably a really important supplement for vaginal health, I think, as well. What are the benefits and harms of Neupogen for transfer? Any side effects? Well, Neupogen raises your white blood cell count. So if I did a blood test on you and said, what is your white blood cell count right now? Pretty much anything less than 10,000 would be considered normal. When we use Neupogen, which is a drug that is intended for people with cancer, people who have what's called neutropenia, and that's where they've had chemotherapy and their white blood cell counts are low. We give them Neupogen to try to help build back some immune system. Well, what it's going to do to your white blood cell count that may be normally 9,000, it's going to suddenly be maybe 30,000 or 38,000. And so then you do a blood test and you check it and see it, and the lab calls with a panic value because that they're thinking, oh, this is somebody who is septic, somebody who has some all over body infection, and that's very, very dangerous. Well, that's why we use that drug, because it boosts that white blood cell count so high. Really, its best use is it actually has a use also for helping to thicken the endometrium, and can be used in certain other immune type states. It is not something that I would consider. I don't use it routinely, It is part of one of the immune protocols at my former place of work, so it was used much more commonly there. I'm not aware of really any other fertility clinic that uses Neupogen routinely. Let's see. Our urologist said there is nothing you can do if the DNA fragmentation is not due to oxidative stress. All right. Well, I don't know that I agree with that because there is pretty good evidence that doing that procedure that's called a TESA, which is where the sperm is extracted directly from the testicle, does result in better sperm morphology. So it would be TESA, it would be frequency of ejaculation, and it would be ICSI. Those would be kind of the three treatments. So the ICSI and frequency of ejaculation, well, that's easy enough done because when you ejaculate is kind of entirely up to you. The ICSI is kind of a standard part of the IVF regimen now. In most cases, you're not paying extra for that anymore. So really the question is, do you need to do that invasive procedure, that TESA? Now, I say it's an invasive procedure. It's not significantly different from having blood drawn from your arm, except that it's having sperm drawn from a testicle. So you might say that's pretty different, but it's actually, as I said, it's not as terrible as it sounds. So the issue I would say with urologists is that many urologists don't have a particular interest in male fertility. And so while I would never in a million years pretend to be a urologist and to have the expertise that most of them do in all the things that they do, I still feel like, well, sometimes we look at a problem a little differently than most urologists do. And that may be, and you can see that from the fact that, well, gosh, when we sit down for a consult with you, it's 30 to 60 minutes that we're going over all this and thinking through the problem. How long do you get with a urologist? You get a pretty quick exam, maybe you get a couple minutes and then they move on. So it's probably a little bit different, although fertility urologists, those are urologists who specialize in male infertility, are really prized, and there are some good ones out there. But general urologists may not have the same kind of focus, if that makes sense. Hey to Peyton. Oh, hey, Peyton. Nice to see you. Dr. Fink, you rock. Oh, gosh. Oh, stop. Okay, one more time. Thank you very much. Should you avoid alcohol or certain foods and caffeine before an IUI? I know everything in moderation, but curious if it should be completely avoided. Well, I got to tell you, a lot of people do a lot of things before they ever realize that they're pregnant. Pregnancy may happen, and then you're not even aware of it until at least a couple of weeks later when you miss your period. And they have done a lot of things that might be questionable during that time period. Alcohol use, caffeine use, extreme exercise, sometimes even certain types of drug use, marijuana and what have you. And in the vast majority of those cases, folks do just fine. To be honest, we're a fairly resilient species, and I feel like there's not a lot that we can do that's going to harm our pregnancies once we actually get there. So even though we want to try to do the best thing for our offspring, and I would say, yeah, you know what, it's probably reasonable enough to say, don't drink. You can hold off, don't drink, and certain foods. You're not supposed. There's 4 types of fish that you're supposed to avoid in pregnancy, and that's shark, mackerel, tilefish, and swordfish. 4 types of fish. I actually had tilefish. I never knew what it was, and finally I had it. It's actually delicious. Swordfish is not uncommon. Mackerel, it's out there. Most people don't eat shark, but mako shark is something that you can see sometimes in restaurants. Shark fin soup, if it's even legal in this country, I'm not sure. You avoid those 4 things. You're supposed to avoid raw things because they can have certain types of pathogens, parasites in them. Once you are pregnant, you're supposed to avoid things like deli meat. So if you get a craving for a ham sandwich, then you should put a piece of cheese on it, melt the cheese, if it's hot enough to melt the cheese, it is probably hot enough to kill the bacteria that can be on that luncheon meat, that deli meat that can cause harm to a pregnancy. And that's called listeria. Um, so, those are common sense sort of things. Can you have sushi after you did an IUI? I think it's probably fine. Could you have a glass of wine? Honestly, I think it's probably fine. Should you not have coffee? Even when you're pregnant, a big cup of coffee every day is really likely not going to be harmful. But as you say, everything in moderation there, and I think that probably makes the best sense. So somebody asked the other day that she is planning to take a trip to Las Vegas, and she was going to be going to Vegas. She was like doing an IUI maybe on Tuesday or Wednesday, and is going to be going to Vegas maybe on Thursday, and wanted to know, should she cancel her trip or should she cancel the IUI? And I said, you can absolutely go and live your life. However, if you were really planning to do a lot of partying while you're in Vegas, and to really kind of drink a lot more than you might under ordinary circumstances, well, maybe it's better to either wait on the Vegas trip or wait on the IUI, because I do think all things in moderation there. So hopefully that is helpful, and I can't wait to see you pregnant, Peyton, for sure. Tara asks, what supplements to help with the vaginal microbiome? So I think we covered that there, and I hope that was helpful to you. Hey, Beach Bum 1207. Let's see. Marlena is here. Jessica is here. Hi to Casey. Nick asked, the first time having a medicated cycle, why don't I need to trigger before transfer? And that's a good question. So, two types of embryo transfer cycles. There is a medicated cycle, and there is a natural cycle, or a modified natural cycle. So in the natural cycle, we are letting your body form an egg in the ovary, letting that egg grow. As that follicle grows, that's what makes your estrogen. And that estrogen thickens up your uterine lining, does all those good things to your uterus. When your body releases the egg, when you ovulate, and sometimes we will trigger the ovulation to make sure that the timing is right and that you do in fact release those eggs, or release that egg, then, as we talked about before, your little estrogen factory converts over to becoming a progesterone factory. So the ovulation is the key part to the natural cycle. And in what we call a modified natural cycle, you are getting some ovulation induction just to make sure that you're going to release an egg. And I think that's a brilliant thing to do. In a medicated cycle, we don't want any of that to happen. We don't want you to release an egg. And in fact, if you're developing an egg, then our medicated cycle isn't working. And those cycles will often get canceled because we're giving you estrogen. We're giving you all the estrogen that you need. Because your ovary's not making it. Then, rather than letting your ovary release an egg so that you can start making your own progesterone, we switch over and start giving you the progesterone, usually in the form of a shot. And that's the progesterone in oil shot. Usually we use that along together side by side with some vaginal progesterone as well. And that's because your ovary isn't making it. So why aren't you getting a trigger shot in a medicated cycle? Because you're not making an egg. We don't want you to ovulate. If you ovulate, then that means you're breaking through and you're going to start making progesterone, and the timing of your transfer and what that progesterone does to your lining is going to get all messed up. And so in that type of situation, that medicated cycle, your cycle will be canceled. So that's the difference between a medicated cycle and a natural cycle. So fingers crossed there. Hi to Mohi. Let's see here. Mrs. Villarreal is here. Rosa Vesta, hello, good evening to Ashes and Ryan LS. Meredith, if you're actually watching, a special hello to you down in Miami. Hi to Jessica. Jessica asked, I read a study recently showing that in a modified natural, using vaginal progesterone only leads to lower success rates compared to cycles using PIO, or progesterone in oil. Well, so in a modified natural, So in a modified natural cycle, you would not generally be using progesterone and oil because your body is making its own progesterone. Now, I haven't seen that study, but to date, the party line has been that a natural or modified natural cycle is at least as successful as is a medicated cycle. At at least as successful. And there are several studies that show that the modified natural may even have a little higher success rate. It may have a little higher ongoing pregnancy rate, and it certainly has a lower risk for certain types of pregnancy complications later on down the line, specifically blood pressure type complications. So I'm not familiar with why that would lower the success rate, because in fact it's the making of your own progesterone that seems to be the magic sauce, as I say, in a modified natural cycle. So there are always evolving studies that show us things that are a little bit different, but there have been a bunch of studies that said, oh, it's not as good, and some that said, oh, it's even better. At the end, what we can say definitively is that the natural or modified natural cycle should be at least as good as the medicated cycle. Now, most cycles in the United States are often medicated cycles just because clinics need to do that in order to, for logistics, so that they can control all the variables. We can control all the hormone levels. I'd be, Jessica, if you want to send me a copy of what you looked at there, I'd be happy to take a look at it because I'm very interested. Ashes asks, have you heard anything about a device called InvoCell? And when would it be used? Yes, so InvoCell is is something that can be used. It is sort of a kind of a cross between IVF and IUI, kind of, sort of, but not really. But exactly that, but not at all. You following me? So basically, you have an egg retrieval. So you go through the first portion of IVF. The eggs and the sperm go together into the InvoCell device, and that device is then placed in your vagina, where it stays, and it's allowed to incubate. So basically, it's kind of using the body's temperature regulation to maintain body temperature and doing what's known as conventional IVF, which is where you just put sperm in the same dish as eggs and hope that a sperm will penetrate the egg and result in fertilization. The reason that most clinics do not recommend conventional IVF is because if they go back and find that your eggs didn't fertilize, then they end up doing what's known as rescue ICSI. And rescue ICSI is where, okay, well, we got a bunch of unfertilized eggs that have been exposed to all this sperm and they're now a day old. So we are going to have to take a sperm and put it in that egg. Now do the ICSI anyway. And the outcomes from rescue ICSI are not good. And so, but that's what InvoCell is. There are some clinics that will offer it. To be honest with you, I think it's fairly expensive. And if you're spending what you're spending to do an IVF cycle, in my opinion, you would want to use all the resources that are available to you to do what science has shown to be extremely effective, rather than something that kind of sounds like a cool idea. You know what I mean? Now, there are studies on InvoCell that show that it works, but again, really what you're doing is conventional IVF. You're just using the body as an incubator, and hey, that sounds like a good idea, but an incubator in the laboratory can also be maintained at a very constant temperature with a very constant pH, acid-base balance, and with the media and everything that's in with the embryos, so that outcomes may be a little bit more predictable. Just my 2 cents worth. Hello to Mrs. Manda Marcus. In a medicated cycle, Shada asks, could you extend the estrogen period for a planned transfer date? If so, how long could it be with no harm? 10 days, 2 weeks? Absolutely. And that's one of the things about a medicated cycle, is that you do have more control over the timing. So you need probably a minimum of about 6 days. A minimum of about 6 days in order to get the lining to grow to the point where it is going to be able to sustain an embryo. But yes, you can control that entirely by just extending the estrogen period before you start your progesterone. The only thing we know there in that medicated cycle is that you need for sure 120 hours of progesterone, unless for some reason we know that you need, your timing is different. But standard 120 hours of progesterone, that part has to be fixed. But when you get it, when it starts, because you're trying to get to a certain date, absolutely. You do have logistics control over timing when you're doing a medicated cycle. Absolutely. Hello to Wendy and the wonderful nurse practitioner Kaylee Gordon from New Life Fertility here in Pensacola. Mrs. Villarreal says, my OBGYN doesn't want to check for endometriosis. She says she doesn't think I have it and that the risks outweigh the benefits. I've had one failed transfer so far. Well, so in my opinion, and again, opinions differ, so I will tell you mine. My humble opinion is really what the American Society for Reproductive Medicine says, and that is you don't do laparoscopy for fertility-related reasons only. So let's just say that you had painful periods. Oh gosh, well, so the three kind of common things that we associate with endometriosis: painful period, painful bowel movement, and pain during intercourse. And let's say, well, you've got that, then I'd say, okay, well, in reality, you may very well have endometriosis, and I'd say a laparoscopy is certainly not contraindicated. However, I will tell you that the most common presentation of endometriosis is that there's nothing at all, and that we go and look and surprise, we found it. There is a non-invasive way to test for endometriosis, Mrs. V, and that is called Receptiva. Receptiva is an endometrial biopsy that's performed at a certain time during your cycle, usually about 7 to 10 days after you've ovulated, that looks for a marker that's known as BCL6. BCL6 is an inflammatory marker that's highly associated with endometriosis. If you have the BCL6 marker, the assumption is that you likely have endometriosis. And then I would say the recommendation is, well, we treat that. How do we treat that? 60 days of suppression. 60 days of suppressive medication, either in the form of Lupron, which is a shot, or there is a pill version, 2 different pill versions you can use as well, or Alyssa and Myfembry. And so, you know, that doesn't require surgery. It's unfortunately not covered by insurance. There's only one lab that runs the Receptiva test because it's a proprietary thing, and so they don't want to take insurance. Your laparoscopy probably would be covered by insurance, but given deductibles and copays and all that other stuff, it's likely to cost you more than the uncovered Receptiva test. But I agree, after a single unsuccessful transfer, Mrs. V, I don't know that I would necessarily be rushing to do a laparoscopy, especially if you didn't have symptoms, because it's not unusual that a single transfer isn't successful. So even if we have a tested embryo, so we do the PGT testing and find that your embryo is chromosomally normal, best we can do there is a 65% probability of pregnancy, which isn't 100%. So after one unsuccessful embryo transfer, that still doesn't mean that anything is wrong. It just means that, well, there maybe was an embryo, anything wrong with you, that the embryo wasn't normal or something about it just didn't allow it to hold on. So concluding that it must be because you have endometriosis may be a little aggressive. As far as I'm concerned. And I do agree that, you know, surgery, that now there are a lot of docs who love to do this kind of surgery and feel like it's a very, very important part. So my, you know, deference to them. Different doctors feel differently about it. But in the olden days, that laparoscopy was part and parcel. It was a very first part of of every infertility evaluation. Nowadays, we know that it really doesn't so much benefit the general population. And there's some question as to how much endometriosis really interferes with pregnancy anyway. Now, the one other thing I would say there is, depending on what kind of embryos you were transferring, and were they good quality, high graded embryos, were they euploid embryos, were they even day 5 blastocyst? Because if they're day 3 embryos, we don't know how those things were going to do. There's many of other factors that kind of go along with that. But I wouldn't necessarily jump to conclude, and this is a good thing, that there's something wrong with you. I think more likely it just wasn't the right embryo yet. But you're going to get there. What else we got cooking here tonight? We got about just a few more minutes here. So let's see if we can get some questions in. If I haven't gotten to your question tonight, please email me at askfertilitywithfink@firstfertility.com, and I will happily get to yours at the top of the next show. I'm so excited. My son graduates from high school this weekend, and I get to go home and be with them. Next week, I will be out of town here, but I will still be doing our live at the same time. That's next Tuesday, 5 o'clock p.m. Central Time. I have Hashimoto's and a positive ANA. Can I still use L-arginine? If I can, when can I start? Yes, you can. And L-arginine is something that I recommend in a transfer cycle only. Please do not use it for fertility itself. It is not something that is helpful to egg quality. And in many cases, there are studies that show it can be actually harmful to egg quality. But specifically for embryo transfer, yes, absolutely. You can start it, really start it in the month when you're starting your embryo transfer cycle. Hi, Florida girl. Let's see here. Oh, Shada says, the world needs more of you. Thank you so much. I appreciate you saying that. That's really very, very nice. Please, as I mentioned, take a look tomorrow at the Instagram post I'm going to place up. It's Randy Fink MD. And I'm going to ask for you to share with us in that forum what you've done to stay on top of your mental health, not just going through life, because we all know that's a challenge day by day, but certainly as it pertains to this roller coaster ride of fertility. It's Fertility Awareness Week. Please reach out to your friends. Let them know that none of us are alone, that we are all here for each other. That said, I got to tell you, every day forward with love, every day forward with kindness, and every day forward with hope, knowing that tomorrow is a new day, and a new day brings all new adventures. This is not the book of your life, friends. This is not your novel. Rather, it is only a chapter. And what are we here to do? We are here to rewrite it together. So until next week, from Pensacola, Florida, I'm Dr. Randy Fink. Thanks so much for being here on Fertility with Fink, and good night.